guys. We're talking YouTube and LinkedIn and Facebook simultaneously. Super exciting. And we are thrilled to have Dr. Dan Nayot with us and our partner, Dr. Tanya Wild, naturopathic doctor. And we are going to be talking about how to increase your IVF implantation success. Now, Dr. Dan, we had you in, oh gosh, you know what? I don't even remember the time frame, but I interviewed you. You're such an amazing, phenomenal speaker, totally there for patients. And we were back then talking about implantation as well. But things have changed. The landscape changes like very quickly. So it's like, oh my gosh, we need you back. And let's talk about how do we increase implantation success. And just so you know, guys, you can go to our episode 65, I believe, which was an interview with an immunologist and fertility specialist. Her name is Dr. Genevieve Jeunesse. And we were talking about miscarriage and implantation failure. So for both natural miscarriages, like naturally conceived pregnancies, as well as those who've had multiple implantation failures with frozen embryo transfers. So we're going to take us another direction because we're looking at testing more than anything, as well as, what do we need to look at, which may indicate that it's a higher implantation rate. So I'm going to have you speak to this, Dr. Dan Nayot. And before we start, can we share a little bit about who you are? How long have you been in practice?
Oh, good question. Well, thanks for having me on, Mary and Tanya. I graduated from McGill University in 2014. So, wow, 9 years.
Okay, cool. And like super honored that you're here because you're actually the medical director for this fertility partners. And fertility partners, there's so many, fertility partners. And you work at one of the locations, which is RCC in Mississauga, but there are multiple locations. I don't even know how many there are.
Yeah, we're 13 locations, 33 clinics across East Coast to West Coast and in the States as well.
Wow. And so you're the medical director there. So you guys, this is high level stuff. So listen to what Dr. Dan has to say. And so let's get with it. And we're going to talk about, first of all, I had a patient a couple of weeks ago and I reached out to you and I said, hey, what's the deal? People are getting transfers now despite having trilaminar uterine lining. So before you address that, I think we would request that you tell us about what the heck trilaminar lining is.
Yeah. Okay. So when I think of implantation, which is an embryo implanting into the uterus, I usually break it down into two systems. I always say there's the seed and there's the soil. So in this conversation, we're going to always assume that we're putting a quote unquote perfect or viable embryo, but we know that many transfers already it's predestined to not succeed because the embryo is not perfect. But for the sake of this conversation, when we talk about optimizing our implantation, we'll make an assumption that the embryo is viable. But just a comment on about a viable embryo, we know about chromosome testing like PGTA. There, of course, are limitations. One of them is that it's just a few cells and it's from the outside, and we use that to assume something about the whole embryo, but it's a great technology in the right context. But also chromosomes is, I would say, a prerequisite, but it's not the only thing. So you need all your bones in your body, but just because you have all this perfect skeleton doesn't mean you're perfectly healthy. So there are more than just chromosomes to embryos. Another window into it is the grading of the embryo. But again, for the sake of what we're going to be talking about, because it's a complicated subtopic, we'll just assume that when we're talking about implantation, that we put a viable embryo that should have worked.
Right.
Okay.
Because of course there's a certain percentage where, just because it is chromosomally normal, how I put it is, it doesn't necessarily mean that that's a baby.
That's right. Or I'd go even more back. A lot of embryos are not chromosomally normal and they can implant, but they will stop after a certain amount. And it's nothing related to the uterus or the environment. It's the embryo.
Yes. And I love it that you say this because, and now put it into the perspective of a patient when they have a failed IVF transfer, there's this automatic sense of blame, like, oh my gosh, this must be something wrong with me. And so you're just putting it out there saying, even when it is shown as chromosomally normal, it doesn't necessarily mean that that is a viable embryo, which sucks, but it's a reality.
Yeah. So even if we have chromosomally tested, confirmed embryos of high grading, we're far from 100% success. And so what we're still trying to figure out, does that mean there's still some embryos that aren't perfect, even though they look good and they're chromosomally normal? Probably. But what about the implantation? What about the soiled, which is what we're going to be talking about? So
Right.
his question was about the trilaminar pattern. So we'll go back. So we do ultrasounds. There's abdominal ultrasound, which is through your abdomen. There's transvaginal ultrasound, which is a probe within the vagina. And the idea is to look at the uterus, and inside the uterus is the endometrium, what we call our lining. And that's sort of what thickens and changes and sheds when we get our period. In the first half of our cycle, this is when our follicle is growing. It's an estrogen dominant environment. Estrogen thickens your lining, but also we see what we're supposed to see is what we call a trilaminar pattern. I mean, I don't have a picture to share with you, but we call it trilaminar because it looks like three lines. You'll see basically the two lines of the endometrium and a line right in between. So we know it's what's supposed to look like. So as a general rule, if it's supposed to look like something and it doesn't, either that means something's off or we don't know why. Okay. So in terms of trilaminar pattern, it's supposed to look trilaminar when there's an estrogen, but sometimes it doesn't. And then we wonder, well, is that a sign that something about the environment's off? Or is it just that it just didn't look that way? For example, sometimes because of the rotation of the uterus, retroverted, twisted, or because of shadowing of the fibroid, when you do a transvaginal ultrasound, it doesn't look trilaminar, but you do an abdominal ultrasound, you see it at a different angle, and you say, oh, there's a trilaminar pattern. So sometimes just because you didn't see it on a transvaginal ultrasound doesn't mean it's not trilaminar.
Oh, that's awesome. I totally didn't know that. So I hope you guys get this. So just because you don't see it on ultrasound, as a recap, it doesn't mean that it's not there.
Yeah,
So
just
then how do you discern?
doesn't mean another way you can't see it.
Sorry, you just cut out for one quick moment. Can you repeat that?
I was just saying, just because you don't see it on transvaginal ultrasound doesn't mean abdominally if you were doing. People don't routinely do it abdominally, but they can if they're looking for it.
Right. So, the couple of people that I've seen that they said, you know what, we're just going to go ahead. I believe that it was just transvaginal. So then is there the assumption that it's there just because it reached the 8 millimeter lining?
I have a few comments about that. So one, when someone says their lining is trilaminar or not, sometimes they just look at the report and say what the report is, but sometimes it's subjective. So if me and you both looked at the same image, I might say, you know what, if you ask me, it looks pretty trilaminar. You might say, I don't know, I'm not really seeing trilaminar here. So sometimes it's subjective. Sometimes it is trilaminar, just the way you're looking at it doesn't see it. But let's just go back. No variable that we're going to be talking about, including thickness, including pattern, including biopsy results, are black and white. So you probably know numerous patients who've gotten pregnant with a healthy live birth with very thin lining, just so you'll see lots of live births with non-trilaminar lining. So I wouldn't say I would use any variable as black and white. So if I saw another physician transfer when the lining wasn't trilaminar, I don't think that's a terrible thing. It's just one data point to consider.
Is there a lining thickness that you're kind of going for, that you're looking to achieve to see?
Yeah, I mean, the truth is that we don't get to choose someone's thickness. So I don't sit there and say, you know what, for you, I'd like 11 millimeters and let's do it. Everybody
A minimum cutoff.
I was just saying that we don't get to choose people's thickness.
Yeah.
People sort of have a peak.
I meant like a minimum cutoff of the lining. Like, is there kind of a minimum lining thickness cutoff that you would say, okay, this
Well,
may be
I
a little
think
too thin?
Yeah, so I usually say, we're talking here about IVF and embryo transfer. So during the IVF cycle, when there's lots of hormones and the estrogen's high, to me, that's a pretty good idea of what your peak lining is going to get to. So if in IVF you can get to 12 millimeters, then it would make no sense for me in future transfers that you're at 4. Something doesn't make sense. Right? But if in IVF cycles you're getting to 6 millimeter, also it's not fair to expect 9 millimeters in our FET cycle. So you got to prepare the patient ahead of time, and you say, look, for you might have 6 or 7 millimeters, and that's what we're going to get to. So when we get to 6 or 7 millimeters, we're not canceling it because we're expecting it. That's you.
Right.
So then let's look at other types of testing, like the ERA, the endometrial receptivity assay. Do you use that anymore, or have you abandoned that?
Yeah, so what in the world is ERA for some of the listeners? So it's called an endometrial receptivity assay. The idea is it's an endometrial biopsy. So we put a little catheter in the tissue, we get that lining, we remove it, and we send it off to check for proteins. And the idea is that the proteins that these genes that are turned on might be releasing might give us an idea of where in this window of implantation. Are we too early, right on, too late? That's sort of the concept behind it. I would say that it's not standard of care. It's not bad medicine if you don't do it. It really depends on the clinic you go to and the doctor. Some people do it for everybody. Some people recommend against it, and some people do in certain situations. With time, we get more and more data. And usually what happens is big publications come out and people swing one way, another big publication comes out and people swing the other way. I would say if you're asking me today in January 2023, the word on the street is sort of feeling that it may not be that helpful. Patients who have done their second transfer the traditional way versus changing the amount of days of progesterone seem to have a very similar outcome. And so some people think it's not worth the extra month of waiting, the cost of the ERA, the extra endometrial biopsy. I'm talking in generality, but again, even the ERA is just one data point for me.
Right. And to be clear, to do that procedure, you will do a mock cycle, meaning you're pretending to go for an embryo transfer, but that is not the month of transfer. And as we know, a lot of women are anxious to get things going like yesterday.
Right.
So that's just adding another month to the mix. So to see if it's for you, and if you want to advocate for yourself, if you really want to get it done, there is that extra month.
I think one thing I've learned over the last few years is the key is to talk about it ahead of time. Because if we do an embryo transfer and it works, nobody ever comes back to me and says, Dan, thanks so much for not doing an ERA, and thanks for, not looking at this or not looking at that. But if it doesn't succeed, they usually come with a list of 11 variables and said, well, why didn't we do the ERA? And what do you think of this? And I saw a podcast about that. All good questions. So it's always best to talk about it ahead of time.
I love
For
it.
example, like the peak lining is a great example. So I always review their IVF cycle and say, look, you're someone who gets 9 to 10 millimeters. I think we can wait till it gets to that level before we start the progesterone.
Okay.
Do you prefer, sorry, I was just going to say, do you prefer in general doing a natural frozen embryo transfer, kind of relying on the woman's ovulation and then using progesterone, or do you prefer using, like, what does the research say, and what do you prefer clinically, using estrase or?
It's funny. I think if you recorded me in different time points, I get different answers. I would say, what's becoming quite popular these days is a more natural approach. And some of the older REIs who were our teachers are saying, we used to do that all the time. You guys you think you're reinventing something, but we used to do that all the time. It's just coming back to fashion. Me personally, there's certainly pros and cons. The patients I think it makes a lot of sense for is people who've conceived in the past spontaneously. So, if 7 years ago you had a baby, you conceived with your partner, you had a baby, and now you're struggling, then I say to myself, well, look, she's naturally conceived in the past. No reason not to trust her own estrogen and progesterone. When we say natural cycle, we essentially we mean you ovulate your estrogen and progesterone, but there's something called modified natural, which is usually what we do, which means, yes, it's a natural approach, but we're tinkering a little bit. We might do the trigger for you. We might give you a little bit extra progesterone. We might do this and we might do that, but essentially a more natural approach. So I like a natural approach if someone's proven that they've conceived naturally. So clinical history for me trumps any test. The second thing is if they're requesting it, they're sick and tired of the medications. It's a cost issue. They don't want to inject themselves, for sure. If they can ovulate, so if someone's in menopause and they need to get the estrogen progesterone because they don't make themselves, then we can't really talk about natural. But yeah, it's relatively more popular these days. Less medications. there's more research showing that maybe the placental invasion and the future outcomes like preeclampsia might be better in the more natural approach. Of course, there's some downsides. We always say that women are not robots. So, we might want a natural cycle, but this cycle you didn't ovulate, or you ovulated early, or something unusual happened. And so it creates more monitoring, more cancellation. So certainly pros and cons, but again, the same concept, you got to talk about it ahead of time.
Love it. And for those of you that are tuning in, we did a deep dive with Dr. Ari Baratz around natural or modified natural IVF fertility, frozen embryo transfer. So you can refer to that, but let's keep going here with regards to other kinds of testing. So there's also like the Emma and Alice test. Can you speak to that and about, probiotic usage and that line?
Yeah. So the Emma and Alice are other tests that we can analyze, but it comes from the same endometrial biopsy. So again, the idea is to take tissue and analyze it. The ERA analyzes proteins that we believe suggest when your window of implantation are. The Emma and Alice are sort of microbiome and infectious testing. It's a relatively new way of thinking. Traditionally, we used to think that the uterus was sterile. You've got their cervical mucus plug. There's nothing up there, but nowadays where we can do like RNA testing, we say, no, it's far from sterile, which makes a lot of sense. You've got lots of bacteria on your skin, tons of bacteria in your vagina, and, why would that not extend up? And so Emma is more about microbiome and Alice is more about specific infections, but I'd say it's a very new field. The idea is that just as in the vagina, you might have more symptoms. So if lactose, we know lactobacilli is a microbiome that you need. And when that's off, we might get symptoms of yeast infections and discharge and odor. And so the same idea is thought to be in the uterus, but it's relatively new. And I don't know where it's going to go. When it's new and it's so complex, we may have negative studies, may have positive studies. It's hard to test.
Right, hard to test because there's way too many parameters to test.
So many parameters. So, Some physicians say, well, until there's more proof, I'm not even going to talk about it. And some will say, why don't we just assume that's part of the problem? Here's some probiotics anyways, or here's some antibiotics and then probiotics. And some will biopsy and biopsy and biopsy until that lactobacilli has to be a certain number before they do a transfer.
So just in your own personal patient population, have you or are you currently using probiotics with them?
So I don't use it routinely. When I say routinely, for everybody, but I certainly do use them where I see fit. Where I see fit is where I think that's the issue. How do I know that's the issue? I never truly know, but I sort of rule out things. So if we're putting very high quality tested embryos in and it's not working, well, that points me to the soil as the bottleneck. In the soil, if the lining doesn't look trilaminar is a good example. And I say, interesting. It's supposed to look trilaminar. Transvaginally, abdominally, it doesn't. I say, maybe that's just you, or maybe that's a soft sign of something's going on. Those are patients I end up doing biopsy for. And then if I find a significant finding, I say, well, look, to me, those dots connect. It makes a lot of sense. So let's give some antibiotics, let's give some probiotics, and then let's try a transfer.
Okay, cool. Okay, next up, how about PRP? Do you utilize that, or can you comment on that?
Well, it's funny. I'm hosting a physician today, and I was talking to her about 1 hour about PRP because she used to work in a clinic that did PRP. So this is a perfect topic. So do you mean PRP for the uterus or for the ovaries?
For both. Like, I guess, because we're talking about the uterus right now, I would love for your comments on both, but
Okay.
maybe first explain what is PRP and then you can give your take.
So PRP stands for plasma-rich protein. The idea is you take a blood sample and you centrifuge it. So you spin it around, and it comes into little segments, and you get plasma as sort of the fluid part of the blood, and you go to the bottom where all the platelets are. So that's why they call them plasma-rich platelets. And the idea is that might have some growth factors and other positive cytokines that might be stimulating. So you've heard of people using PRP for their hair, for hair thinning. People have tried in the ovary in the premature ovarian insufficiency. And the idea is maybe in the uterus, it can stimulate the endometrium to grow. Again, this is one of those brand new interventions. I would say most of the literature uses it in the thin lining community. When you're lining a skin is an idea to help it. If so, everyone does it a little bit different. Some will do it at the start of the cycle or mid-cycle and things like that. I've personally not done it. I'm following the literature. I mean, I'm cheering for it. We're all looking for any intervention we think is safe and will improve outcomes.
So it is safe, meaning that, if you choose to do it, there is no harm.
Yeah. I mean, I would never say no harm, because even taking blood can have an infection. But the idea is it's your plasma, so you shouldn't have some sort of allergic reaction to it. So if you were to do it, I would do it in a clinic that does it routinely or experience with it. You don't want to be the first 3 to go out in the clinic, because that's where the mistakes happen.
Right. That's a really good point. And how about embryo glue?
Well, I think it's the best named intervention I've ever heard. The idea about embryo glue, which is hydrolonic acid, is that when we do the transfer, we put the embryo in a little catheter, and sometimes we put it with something called embryo glue to try to maybe help with the attachment and implantation. Again, I don't think, if you ask me, the studies are consistent. They're not consistently negative and they're not consistently positive. I would chalk that up as a no real downside. It's not a negative intervention. It's something that's added to the embryo near transfer. The only real downside is maybe the cost and the lack of evidence.
Do you know how much it costs actually offhand?
I think it depends on the clinic. I'm going to guess it's in the $500 to $1,000 range. I can't get more than that or less than that, something like that.
Okay.
That's an estimate, yes.
Right. No, for sure. And so here's the thing. There's so many things that there's so many tests that you can do. There's so many interventions you can add in. It can be so confusing. So what do you tell women going through if they're like they're that type A person and they want to try everything? Like, do you just let them? Or do you have like a solid conversation? Do you know what I mean? Like you have the money. Or you don't have the money. It's like, what's the bare minimum that I should do, or how much should I do? Right? It's a very fair question.
It's a good question. I mean, some physicians sort of don't want any patient to be upset at them if they don't succeed, and so want to offer them A to Z. Some physicians are the opposite, and they say, unless there's strong evidence, I should not offer you A or Z. And some are sort of between. I think the key, sometimes patients come in and they know exactly what they want, and you're there to guide them. And as a general rule, if it's not harmful and it's logical, then it should be, why not, support them in their decision. If you think it's harmful or illogical, then it's your job to guide them. Some patients really, because it's so stressful, they don't want, again, if it succeeds, nobody comes back and, appreciates you not doing something. But the key, some patients want to give you the responsibility, because if it didn't work, it was my decision, as opposed to them choosing which one do you want from A to Z. And if it doesn't work, second guessing themselves. So I think our job there is to educate and guide. I think what I usually say is there's no consistent finding, or else we would all be doing the same thing. Mm-hmm. But, my mantra is always logic times persistence equals success.
Logic times persistence equals. Oh, I love that. That's a great equation. I love math equations.
Yeah. So, if we're going to say, whatever intervention you do, if you can follow the logic and it doesn't decrease your chance, it makes sense. You got to keep trying.
Well, you got to keep trying, but what's that adage? It's if you do the same thing over and over again, and then that's the definition of insanity, right? And it doesn't work out.
Yeah, but I'm not sure over and over again means one more transfer.
Right, well, yes, okay, fine. So then, okay, if you had multiple failed IVF transfer cycles, are you looking to switch protocols, or do you sometimes do the same thing? I know it's really case dependent, but I would love
Well,
for you to
I
give us.
think the way I approach it is, think about it like a puzzle. So you put an embryo in and it didn't implant. So again, you got to consider the embryo, you got to consider the environment. So first, let's dissect the embryo. Was this a tested embryo? No. How old was she? 42. Okay, well, 80% of embryos that are untested, 42, are, abnormal. My best guess why it didn't work was the embryo, right? And so I don't think you need PRP if I put in an abnormal embryo, right? If, okay, it was a tested embryo, but it was a low grading, I say, okay, well, it could still be the embryo. If after thawing, it didn't really re-expand really well, then maybe it didn't do so well after thawing. You got to look for clues along the way. If you do a transfer and she says, I contracted COVID and I had a deep fever for 5 days and the transfer didn't work. Again, I don't know if that's why, but it's very logical to say maybe if that bad event didn't happen, it would have worked. So it makes sense to just try the same protocol, right?
Mm-hmm.
If she says, look, you gave me this progesterone, but I'm spotting for 5 days before my beta, I say, well, really, usually you wouldn't spot. I wonder what's going on.
Oh, he cut out.
Can you hear me?
Uh-oh, you just cut out. Can
Oh,
you
no.
repeat? And then you're kind of frozen. Hmm.
Hello?
Get you back. We're here. We're
Oh,
here.
I'm sorry about that. I was
That's
going to
okay.
say, if you listen to the history and she might say, I was spotting for a few days before my beta HCG, well, then you might say, okay, well, maybe for whatever reason, you may require more progesterone. So next transfer, maybe we increase your dose, or maybe we try a different approach. So that's sort of how I approach it. At least try your best to follow the logic.
How do you approach dosing of progesterone and baby aspirin? We were talking to Dr. Genevieve, and she said that at bare minimum, those are the two most effective, helpful kind of substances for or medicines for the immune system to kind of help modulate it before implantation. So do you agree with that? Like baby aspirin and progesterone for everybody, kind of as a blanket treatment, or even those are individualized?
Are we talking about anyone who gets pregnant or embryo transfers?
I think both.
Or for transfer more?
But we're speaking specifically to
Transfer,
transfer
correct.
because you're the fertility doctor.
Yeah.
That
I would say most clinics use baby aspirin, not so much that the evidence is there, but more because it's so cheap, it's so easy, very minimal side effects, and ideally it has a positive benefit. So why not?
And so is it helping with the immune system, do you think,
yeah,
primarily? And
that's
then
the hope.
circulation? Yeah.
That's
Okay.
the hope. But it's not that we do believe the immune is an important part of pregnancy. I think everybody would agree the immune is a key component, but not everybody has an immune problem.
No.
right. I think it's something. What is it, like 3% maybe?
Yeah, I would say I have no idea. We don't really know how to test it. We don't know how to diagnose it. We don't know how to treat it.
Mm-hmm. Any
Right.
other thoughts around all this and anything that we didn't bring? Oh, you know what? Actually, back to the aspirin bit. What if, or even fragment? So people will use a higher grade like blood thinner, right? Like fragment. And so I've witnessed it where they're like doing the fragment injections on their own, and all of, like they're like spewing blood. It's like coming out, oozing out. It's like, is that normal? Should we really like have that kind of high dosing on this woman when her belly is completely black and blue? Is that okay?
Yeah,
Do you mean she's bruising, like with the injectables? Is that what you mean when you say spewing out? Okay.
Yeah,
Yeah.
literally,
to
like
clarify.
it goes in, and then the blood is, after they take away the injectable needle, they start actually bleeding because the blood has thinned so much.
So I think that's a good example. So in any intervention we make, we got to do the pros and the cons. And you just added one on the cons list when we're talking about fragment. You can also add cost to that, and so, but it makes sense in certain situations to at least try it. So if you've got a bunch of beautiful embryos and recurrent miscarriages, and you've done some clotting tests that show some positivity, then it's a good way to connect the dots to say maybe there's a micro clotting issue, and fragment makes a lot of sense. So let's try that.
So, and then you would continue even if there was that level of bruising and bleeding.
Well, no, then I would try to either move sites or think of another way to provide blood thinners.
Okay. Just because I see it, so I thought that I would ask you directly.
Yeah.
Okay, this is awesome. And I think one more test, the matrix test.
Yeah, so the matrix test it's an ultrasound. And the idea is you take this ultrasound 2 days before the transfer. So this is after progesterone, but before transfer. And you take a picture, and it's sent to the matrix, headquarters, and they come up with a score. It's unclear. I think this is a combination of visual scoring and an opinion, and then they come up with a score from 10. And the idea is if it's above a certain number, then maybe it's a secondary reason to proceed, and if it's below a certain number, maybe it doesn't look good and you don't proceed. So last time we spoke about the compaction research that was done a few years ago, but it's the same sort of concept. It was an ultrasound prior to transfer as like a secondary safety check.
Right. So are you still looking at endometrial compaction since we're on that topic?
I would say a lot less now. But again,
why?
I don't. It's a combination of the workflow and the clinic I'm at compared to before, and if you remember last time we were talking about the compaction. One of the issues with the original compaction study, which I think is onto something, is that the first ultrasound was done transvaginally, and the second ultrasound at transfer was done abdominally, and so it's harder to compare. So I do think that it makes sense to look at the ultrasound one more time before transfer, because you might at least pick up outliers, some extreme changes. But yeah, I think for sure we know the endometrium makes changes when the progesterone's there. You can see it on ultrasound. You can see the pattern clearly going from trilaminar to what we call luteinized or luteal, where it looks like somebody's colored it in gray. So there's definitely a lot of changes. So implantation is complicated because there's so many variables and there's so many microscopic stuff we cannot do. I think it's getting more complicated as we get more potential tests, because the patients drive themselves crazy and the doctors are just as frustrated because we don't know the answers to everything. But I think as long as you make your best decision, like at least my approach is when we sit down and talk about it all, whether it's testing and we come up with a protocol and the protocol is written, then she's already tried her best and we can't control the outcome. But there's no feeling as what if I would have done that, because we've already talked about that.
Right.
Then I always say you either succeed or you learn. And then what happened during that transfer and what can we do? Is there any insights we can use to adjust for next time?
That's great. So now we've done very heavy all on the medicalized side of it. And we wonder how often you integrate or suggest natural medicines, nutritional supplementation, dietary, exercise, and acupuncture. Do you speak to that with your patients?
Me personally, I co-manage the patients with naturopath all the time. I think I'm not trying to be nice because I'm on the podcast, but I think we look at it from different points of view, and you want to optimize what you can. Like I always tell patients, you can't change age, you can't change your genetics, but you can optimize your situation. And then you can do that as many times as you can until you succeed. And I think that's where you guys come in. So, insulin is great, but it's probably not as great as weight loss and eating well and exercising. I talk about it, but I'm no expert in nutraceuticals. And so I usually refer to the naturopaths to help me.
That's awesome. And how about just, to finish off, because I know you got to go. So we really value your time and you're in the car, by the way, because, we got to be open and honest. And so it's like you're taking the time to be with us and you're in the car doing this. So Any kind of fun success case you want to share, like recently, or that comes to mind?
Off the top of my head, one case comes to mind. There was a patient who came to me for a second opinion, and she's had recurrent miscarriages. And we did a workup. It was normal. She was, I don't know, in her mid-30s. We decided to proceed with IVF. Just generally, it's the most efficient thing we can do. We did IVF, and we got, I think it was 3 euploid embryos, and she had an interesting reaction. Some people were very excited by that because that gives them 3 opportunities, and she was actually quite upset. And I said, okay, what's making you feel upset? And she said, well, that's clearly not the problem. I can obviously make euploid embryos, and so I don't think that's going to solve the problem. You're going to put these embryos, I'm going to miscarry. And I said, it's a really logical way to think about it. And we reviewed her IVF cycle, and this is a case where the lining looked very different from my trilaminar lining. And I said, well, maybe you're right. Maybe this is a clue. And we went ahead and we did an endometrial biopsy, and we did the Emma and the Alice, and it was very abnormal results, not just slightly abnormal, but quite an outlier. And we said, okay, well, here's a new data point. It makes sense to me that maybe that's part of the problem. We treated with antibiotics. We treated with probiotics. We did the embryo transfer. Lining looked great. Embryo, live birth.
Yay.
Wow,
Yeah.
that's amazing.
I mean, hard to, you can say maybe she would have had a live birth anyways if you would have just put that embryo and she finally had a euploid. It's hard to know what the reverse would have been, but it was one of those. What I found fascinating about that case was her reaction and how logical it was.
Wow. Yeah, that's not a typical reaction for sure. So thank you for sharing that. That was amazing. And any last words of advice for the listeners and viewers out there, Dr. Dan?
Well, I think I would say advocate for yourself, ask the questions, figure out the logic of why you're doing something and why you're not doing something. And I mean, again, be logical, be persistent, and good luck.
Thank you. So we will have in our show notes all your contact information, but just offhand, what is the RCC website for them to find you?
Oh, I should
Do you
know
know? Sorry, I put you on the spot. Well, you know what, guys? Google Dr. Dan Nayot.
RCCfertility.com.
Maybe that's what
Probably.
it is.
It should be.
Okay, great, awesome. And then for those of you that
It
want to
is.
speak
I
to
just
Dr.
Googled
Tanya.
it.
Oh, okay, great.
First came up like Royal Caribbean something, but then when you put in the fertility.
Right.
So
yeah, okay. That's if you want to go on a cruise, you do RCC there. But then if you want to see Dr. Dan Nayot, look for the fertility piece for .com. And so thank you for being with us. And guys, check out all of our other podcasts on all things fertility because we're here to serve you. And actually, even beyond fertility, right? Because we cover prenatal period, postpartum, all the way to menopause. So check us out, and you can reach us at aliveholistic.health.ca, and we look forward to seeing you real soon again. Take care. Please DM us. Let us know what you want.
Thanks so much for hosting me. It was really fun.
Guys. Oh, thank you so much for being here. It was awesome. Now, we'll have you back.
Thank you.
Don't worry. We'll talk later. Take care. Safe drive. Bye.
Bye.